Test. Hello, everybody.
Hello, happy Friday.
Happy Friday. Gotta love the Friday after the first part of your week was a conference, right, County friends?
It's been a long week. That's all I have to say.
I'm with ya. Gonna give it just another minute or so. Thanks for being on time and patient. Um, Heather Durosco or Heather Walker, do you have slides or anything like that that you need to be able to share your screen
Yes,
for? Okay.
we do, but also I haven't heard from Logan. I know she was at State Board presenting a massive roll packet. But I know Dennis is here. Dennis, have you heard from Logan?
I got an
Uh,
email from Debbie Old Metal with Logan saying that State Board was running over, and so that they probably wouldn't be able to join.
but Logan went over her slides with me, so I'm prepped to do her part.
Perfect. Yes,
Dennis,
Katie, so we'll just
okay,
share whenever if you give us permission.
okay. Dennis, do you need to be able to share separately from Heather?
My presentation is Heather's presentation. It's just a different slide. So
Fabulous.
so I'll just let you know, like we'll just let you know when it's time to move to the next slide. Okay.
Heather, I just made you co-host, so you should be able to share. Okay, so I'm gonna hand it over to good morning, everyone. Happy Friday. Thanks for being here. Welcome to Tackling Barriers. I'm just jumping right in. I'm gonna hand it over to Heather Durosco from the Colorado Human Services Directors Association, Heather Walker from the Weld County Department of Human Services, and Dennis filling in for the Colorado Department of Human Services to talk about specialized foster care placements. And then after that, HICPUF has some updates on a similar front that they'll be talking through as well. So I'll hand it over to you all.
Thank you. And Katie, can you guys see my screen of just the presentation?
Yes,
Okay,
looks great.
perfect. So just jumping in, some of you have probably seen my crazy visuals before when I've tried to track um, some of the changes on the continuum of care for non-residential treatment all the way back in 2021. So really, this visual is just showing some of the big changes that started happening going back to 2021. Therapeutic foster care did not exist at the time. So the rule was published, the rates went into effect that year. Respite rates were added to all the foster care levels. Um, Treatment foster care at the time was there were only two left. Rates were too low, and we had been losing those providers that had previously offered them. And then, as you all know, professional foster care did not exist because We have only recently started that as a pilot program in Colorado using ARPA funds during the pandemic. So that is still pretty much in its infancy, and there are just a couple of CPAs who license and manage the professional foster care homes that are still considered a pilot. So just wanting to pull out one other thing on this slide. Um, a lot of the ways that we've had very limited funding that has supported kind of ramping up this level of care. One of them has been our Family First Transition Fund source that Colorado got from the feds. And the other one was during the pandemic with the stimulus funds approved. And those stimulus funds have really largely supported all of the state contracted therapeutic and treatment foster care beds set up through the CPAs. And I was just seeing if we're going to go more into the capacity, so I'll skip that for now. And then on this slide, we just threw together the language from 1038 because we wanted to just call your attention to there are two distinct things 1038 requires. The first one on this slide about that HCPF shall develop and implement a plan to increase access to treatment foster care under Medicaid. And so that's what Jenna and Robert are going to share about in just a little bit and go into those details. But then really the second piece under CDHS, the department shall analyze the location of existing capacity, where gaps exist, barriers to expanding specialized foster care, and provide recommendations to achieve network adequacy statewide. So a lot of the work that we're going to share with you in this presentation is going to be focused on that second set because we've been doing a lot of information gathering from CPAs, from counties, and from the actual families that provide this level of care. And then Dennis, I think you're up for a couple of slides.
I am. So this slide shows the governor's wig and talks about the governor's wig and what we're doing there. So in 2024-25, the WIG was adjusted to focus on reducing the numbers of youth awaiting QRTP and PRTPF beds by 25% with a 3-year goal reduction of 75%. So we know that getting youth into beds is a lot more complicated than just creating more beds. And I can give an example of that. Like we can create like let's say we create 5 more QRTP beds. That doesn't mean they're going to take 5 high acuity youth. In fact, most likely at the QRTP level, they're maybe going to say no to taking like a high acuity youth. So we also needed to focus on another problem, whereas the children and youth that we do get into PRTF and QRTP that are high acuity youth often just get stuck there for long lengths of time. I don't know if Brandon Miller's on, but he can speak to that too a little bit. But what I would say about that is we need to build out the lower end of the continuum. And in this case, that means treatment, foster care, and specialized foster care and professionalized foster care too. So here you'll see in the chart just the numbers overall and where they've gone. So the thing about the numbers here listed on the chart is that these are licensed bed numbers. And I think it needs to be spoken to a little bit because often when we're talking about licensed numbers, that doesn't mean those beds are available. An example might be a treatment foster care home might be licensed for 6 children or youth. And they might be calling their CPA or their county to say, hey, I can't serve 6 children or youth right now. I can maybe only serve 2. So the data here is showing the continued expansion of therapeutic levels treatment of specialized foster care. But what it's not showing us is the actual number of foster care beds that we have. So can we go, oh wait, sorry, one more thing on this. Okay, can we go to the next slide? Or do I, because I'm not presenting, so I can't switch. Can we go to slide number 6?
I have the specialized foster care capacity slide up, slide 6. Dennis, are you not seeing it?
Oh, yeah, okay, sorry. I was looking at my own screen. Sorry.
No worries.
Okay, let me just scroll down here. Okay. So here you'll see, and Logan's the one that created these graphs, but here's her attempt to show a graph of who holds certifying authority over the 242 specialized foster care beds we have. But the data is different among those 242 licensed beds. That only actually represents 74 homes across the state. There are 74 treatment and therapeutic foster homes. Some of these therapeutic homes may be licensed for 6 youth, which is why you see the difference between 242 beds across 74 homes. What I want to make sure to highlight here is that, which is quite evident from the visuals, that the CPAs hold the vast majority of these beds and homes across the state. They're also at this point working rapidly to expand this level of care, which is great. But at the same time, we still know that we don't have enough of what we need at this level of care. And that we know that's true because we have children and youth stuck in PRTFs and QRTPs that we're unable to step down. And then, we did talk about like the difference between licensed homes and what's actually available. I'm going to give that example of beds too, along with facilities too. So a good example would be Southern Peaks as a PRTF. They're licensed for 136 beds. However, at this point, they're operationally only serving 48 youth, up to like maybe 48 youth. Every facility, agency, or home gets licensed for a maximum capacity, but typically operates below the license capacity due to the needs of youth supervision requirements and funding. The other thing that we see with our facilities, a limiting factor for them is workforce development, getting the staff they need to be able to operate the number of beds they need. Another thing we found too, we along with Southern Peaks found, is that when you're serving really highly acute children and youth, you have to be very cautious about the number of those children and youth that you put on one campus, so to speak. Okay, so another thing that I think we should emphasize here is the divide between CPAs and counties and why that's happening as far as like development of therapeutic and specialized foster care. And I think we can point to one thing in specific, and that might be the ability to fundraise. CPAs are often nonprofits. They have the ability to fundraise in ways that counties can't. So I want to give an example here. Kids Crossing, I think it was a few months ago, several months ago, Kids Crossing hosted a laugh-in a few months back where Lee Osterly and others told jokes on stage to raise money for the recruitment and retention efforts for their foster parents. And they spent a lot of that fundraising money on tutoring, foster parent support, and respite programs to help the youth in those foster homes to incentivize providing respite for the therapeutic and treatment foster homes, and for monetary gifts, like special meals and other things like that for their homes. And counties really don't have the same latitude to do that. That's where we think some of the differences may lie in the CPA's more nimble ability to create these specialized levels of foster care. We can go to the next slide, slide 7.
It's
Okay, so then we're looking at, this is just a map of where the homes are located. The stars indicate treatment foster care. And as you can see, we have far more therapeutic foster care. But I think the map is important to look at because you see them bunched all together, pretty much in the metro area and a little bit north, right in the central part of the state. We have nothing really. We have nothing on the western slope. We have nothing. We have one home in that looks like it's Durango. So that's going to be La Plata County. And then we have nothing in the southeast or northeast corner of the state, or is just the eastern part of the state. So we know where we need to focus as far as developing these specialized foster care homes. We have been reaching out to CPAs to talk about how they could expand into these different areas. And CPAs seem really willing to do this, but they keep coming back to the main limiting factor of specialized foster care, which is the difficulty in recruitment. That seems to be the most limiting factor for them.
And Dennis, I just wanted to clarify, the STARS are the professional foster care
Oh, sorry,
homes.
professional,
Oh,
yeah.
no, you're
Thanks.
fine. I know it's up there, but just wanted to call that out. And then the other reason we really wanted Logan to put together this map is because we've heard so often from county department directors that it would be super helpful to see the actual locations of where these homes exist. And this is the first time we've had a visual. So just really appreciate you guys putting this together as a starting place.
Well, then it also really points to where we need to recruit, where the areas of the state that are pretty much deserts as far as this specialized foster care. Okay. The survey response, I don't know, that's not my slide, right?
That's me, yeah. Does anyone have any quick questions for Dennis on any of the capacity pieces or the WIG quickly before I go into some of our survey responses? Okay. All right, I'm gonna go quick because I know we don't have too much time. A lot of you on this call have also already heard me present about our specialized foster care survey responses. We collected these from CPAs and from county departments of human services back in September, so you can kind of see the breakdown of respondents there. Specifically for the county and CPAs that do have specialized foster care, these were the questions that we asked them on the survey that we gathered a lot more qualitative data about. And so I think in terms of encountering challenges, it's what you would expect with difficulty recruiting and difficulty sustaining this level of care if you have one home and that home gets burned out. I think that all CPAs and counties mentioned that the initial work of sorting through and getting the policies and procedures in place to launch the program is a big lift, which I see Heather shaking her head, and I know she can absolutely speak to that in Weld. And I think also from CPAs, we heard that these placements are really hard, and so they do require that extra staffing to support families, and it takes a lot more work to kind of have that ongoing touch base all the time. In terms of recruitment, this is a big piece I think we're finding from the survey responses. CPAs really do have a budget that is much more robust for targeted recruitment, and counties just do not have that additional piece. So there is a pretty distinct difference, I think, there in terms of recruitment, whether you're the county department operating this program versus whether you're a CPA. And then the other thing we found is obviously you would expect that most of your homes you're recruiting for this level of foster care are your veteran traditional foster homes that have been around for a while. You're not usually seeing that a cold calling and getting recruitment of a random family, they're going to automatically offer this high level of care. So I just call that out too, because counties really talk about the reality. If they're already limited with their traditional foster care homes, they don't really have a bench to pull from to get folks certified to offer the treatment and therapeutic, because it reduces your capacity overall. And then for the counties that do not have specialized foster care, just wanted to show you all the breakdown here. There are a lot of other counties who are very interested in creating this program. And as you would expect, most of those counties are counties that actually administer foster care programs already and contract with CPAs. And that is different than the counties, those 8 who said they're not interested. in administering this level of care are mostly small counties that rely solely on CPAs for their foster care placements. So just wanted to call that out when we think about targeting who else can stand up these programs. And then the biggest thing on this slide, if your county is interested, what do you need? So this talks about some of the biggest challenges here. And then on the right, these are the themes that we pulled out when we asked for what support would help your county department overcome these challenges to implement specialized foster care. Sorry, I'm going super fast. And then this last piece here, so we asked all county respondents, so 24 different departments, has your county been able to access any of the existing specialized foster care options through a CPA? And what I'll call out here is you're seeing only a third of respondents, so 8 said that they actually have accessed one of the state contracted beds for this level of care through CPAs. There were a ton of comments just about there just appears to be no availability when looking for these homes, or the type of the population, the child or youth that's needed, the homes won't take them, or there's no open beds for those specific homes, even if it appears that it looks like there's available license capacity around the state. So just wanted to call out that I think we're still really trying to dig into that license capacity versus operational capacity. And when counties are looking for a home through a CPA, even that gap when you're really in need of a placement, and is it available or is it not? Okay, and then Heather, over to you.
All right, so CHAMPS partnered with CDHS to do a survey specifically to therapeutic, foster, and professional foster parents. And when they send these out, they partnered with the state and got email addresses and whatnot from each of those areas. So there was a little bit of nuance in regards to regular foster homes, just a few that hopped in and did some response. And this survey is still open, so it is continuing. Their goal is to get to a 30% efficacy of response, and they're not quite there yet. So just this slide just gives you a little bit about the demographics. And I would just point out here that 40% of them are 6 years plus into this, and that the respondents are primarily female between the ages of 35 to 45 and Caucasian. And then 5 are certified by SAFI, 5 by Envoy, 3 Savio, and 2 are La Plata that have responded so far. So you can go to the next slide. There were 31 questions that were asked of the foster parents, and this one stood out to us. This is really one of the areas that we talk about within the specialized foster care work group, about the behaviors and circumstances that they will not take. And one of the areas that was surprising was the eloping. We thought for sure the running aspect would be a high piece, and it is not. You can see it's animal cruelty, sexual victimization, gang involvement's in there, physical violence is in there, fire setting, and then the next slide, because there were a lot of choices for them to ask, and that just gets into a little bit more of more specific of what kinds of children they will or will not take at that level. So you can go to the next slide. And then we asked, or CHAMPS asked, what resources or services have you used for youth in your care? It is everything. Honestly, I think this slide and the next slide really show the vast need of what these families are going through and the needs of what the youth have. So the out-of-home therapy, the in-home therapy, the specialized therapy, crisis supports, mentoring is up there. And then on the next slide, it's the school aspect with the IEP and respite care and the extracurriculars after school. Those are all things that speak volumes to the need, but also the respite care and the extracurricular are definitely a couple things that we've talked about in our group about how do we continue to build that as counties and what does that look like? Because we don't always have the funding for some of that, especially the extracurricular piece. And so to the side, what have been barriers that have prevented you from accessing these resources or services, not knowing what service, the location or availability, wait list, costs, lack of service providers. Obviously, sometimes these youth don't want to participate, and then just finding the actual service. So continued support is really needed to wrap around these homes and families to be able to point them in the right direction for the needs. Okay, next slide. Finally, for challenges and successes, what they responded to were their challenges, were their biggest challenges, were the lack of one-on-one coaching, the wait lists, poor communication, system is not child-centered, and not being treated as an equal part of the team. Their biggest success were the increase in reimbursement rate allows for a greater level of care and enrichment, watching kids grow, maintaining relationship with kids and families for post-reunification, which really speaks to that biological family involvement and how important that is to continue to help support that youth or child in the success of where they need to go next. And then the last slide really talks about, and Heather, you can jump in to help explain anything, but essentially the trails data obviously is what's missing from this particular presentation right now. Dietrich Godinez with the state is working on the data. She has presented it to the Specialized Foster Care Work Group a couple times. We've worked through a lot of different things. We discovered that Weld and La Plata and Larimer, those three for sure do not have their data within the scope of the full picture of what she drew down. So we're digging into the why behind that. It's been brought up with Mod Squad so that they are aware, and that just happened this week. And so we are in the mix of really trying to figure out how do we get this information and work on it. But preliminarily, we would say it appears that those youth stepping down from the therapeutic treatment foster care level are not moving up to a QRTP or PRTF, and that there is longer lengths of stay than what we would have thought in the therapeutic level. So the data that we really want to share is the total number of children and youth since 2021 that have accessed and ended the level of care. And then where they were before and where are they going next? Where, how is this progression happening? What is the story of each youth so that we can really determine what's working? And then the average and median length of stay is the last and final thing. So that brings us to any questions.
Just want to say thanks, Heather, both Heathers, for working on the survey and putting this together for us.
Yeah, there's just been a lot of thought and information gathering that has probably happened over the last 6 months intentionally, but it does take a long time to kind of put it all together. And there is a county work group that Heather Walker initiated because Weld and La Plata were the first counties to roll out their therapeutic foster care program. And that group started organically, meets monthly to really talk about, are you guys trying to do this? Are you having issues with your crisis support? What are you doing with, how are you supporting families with this? And Heather is just starting to also wrap in some additional CPAs so that counties can also learn from CPAs and vice versa. But again, that group is very organic and informal, but cares really a lot about the pieces in 1038 that have to happen on the HCPF and on the CDHS side, and are hoping that this information really helps the state departments move forward with those provisions.
Well, if there are no questions, Robert Worthwine and Jenna Cap from HCPF are also working on a plan on this front pursuant to House Bill 241038 as well. And I think you were hoping to get some feedback on that, if I am recalling correctly.
Yeah, thank you, Katie. And I have a short slideshow. So I don't know if I have capacity to share yet or not, but
I just sent it to you.
perfect. Is everyone seeing this?
Looks great.
Perfect. Good afternoon, everyone. I'm Jenna Kapp. My pronouns are she, her, and I am the Children and Youth Behavioral Health Implementation Policy Manager at HCPF. And joined by Robert Worthwine, I'm going to be presenting a little bit over what we're looking into for this plan that comes out of House Bill 241038 requirements. And then what is going to happen is we're going to share out this plan for everyone to give feedback. And so this is really just kind of an overview on what we have placed in the plan, and then you'll get some of that time to review it. And so the goals for this meeting is highlighting the requirements and then reviewing the plan, specifically what is currently reimbursable under Medicaid, either via the RAISE or through the fee-for-service, and then ensuring the Medicaid system of care can meet the needs of treatment foster care providers and the kids receiving services who are placed in treatment foster care. And then we're going to, one of the parts is collaborating with BHA to identify if qualified behavioral health aides or QBHAs, if treatment foster care parents could become QBHAs, and then therefore a different reimbursement process. And then, as what's been discussed, is the need for increased access to respite services. And so focusing on that as well. And then what are some of our next steps? And so I'll just briefly talk on this. I know it's already been discussed, but out of House Bill 241038, it states that HCPF has to develop and implement a plan to increase access to treatment foster care under Medicaid. And so that's really what this plan is going to focus on. As we all know of what treatment foster care, it's defined as a clinically effective alternative to residential treatment facility, to a residential treatment facility that combines treatment technologies typically associated with more restrictive settings, and having that provided in a more nurturing and individualized family environment. And so really what this plan is aiming to address is increasing that access for kids who might need those more intensive services, but in that home-like setting, as research has shown that there's a lot more benefit to the kid and their overall well-being in this environment. And so I'm talking about a little bit of the current reimbursable services. So we've got intensive outpatient, or not really IOP, but intensive in-home services. And that's reimbursed through the RAISE, medication management, which is reimbursed through the RAISE, and then ABA therapy, physical therapy, and occupational therapy, which is through fee-for-service. And really what we're looking at from that point of view in this plan is recognizing that this can be confusing to figure out how to bill for providers. And so not always wanting to enroll in Medicaid as a provider, and so limiting that access. And so we're going to be working on the backside of clarifying billing guidance for how do you access these services, how do you bill for this and get that reimbursement, is really what that portion of this plan is looking at. And then kind of the bigger part is this larger plan that is being created. And right now we're talking about the smaller treatment foster care plan access. What it is this Medicaid system of care of providing intensive in-home based services for high acuity youth. And so one of that is making sure that kids who are in these treatment foster care settings have access to this Medicaid system of care services, that they're able to be provided in these homes. And these services that are included here is an enhanced standardized assessment, and then enhanced in-home based treatments, which can include multisystemic therapy, functional family therapy. So those will have increased rates, which in turn, we all know increased rates can be helpful for more provider and increasing that access. And then also intensive care coordination through high fidelity wraparound through the NWIC model, and having that certification process. And then crisis services, their current crisis services, and then some of the plan with this Medicaid system of care is increasing the crisis services as well through a phased approach. And so again, making sure that treatment foster care children and youth have access to all of this, ensuring that if kids are in treatment foster care, that their treatment foster care parents are involved in the treatment planning and the meetings that happen within that high fidelity wraparound kind of model. And future state that will also include this is identification tool to see who is actually who can access the Medicaid system of care services from these enhanced rates with that behavioral consultation, and then support services with that respite. So that's kind of the bigger part, is respite. How are we increasing respite, making this more reimbursable under RAISE, whereas it's kind of more limited within waivers or maybe from county dollars. And then therapeutic mentoring, having that other added support for children and youth in these settings. And then the last one is just intensive care coordination through FOCUS, which is families experiencing meaningful connections, outcomes, coordination, and unconditional positive regard in the short-term process. It's by NWIC as well. And so it's just another intensive care coordination that we will be rolling out. So it's not just going to be high fidelity wraparound, but also FOCUS will become an option for individuals in these settings. So really what we're looking at on the respite side is how do we increase access to respite? And so really looking at how do we increase this outside of waivers and making sure that it's billable to the RAISE. And so focusing on what is our enrollment criteria for these providers? Do we need certification? What does that look like? And so that's what we're working with CDHS and BHA of identifying what that looks like. And then figuring out how can we put that within the RAISE structure. And then also with that, having a tracking mechanism to ensure that these respite services are being delivered as promised and in an appropriate manner. And so those are kind of the main, that's the component of increasing that access. And then one of the other big parts that I talked about is increasing the access for treatment foster care placements. And with that, we need more parents. I know that was talked about earlier. And so working with the BHA to identify if the qualifications currently for their qualified behavioral health aides could be a requirement or certification for treatment foster care parents. And then they would be able to bill under a licensed clinician and have that reimbursement process as an additive if they're providing some of the behavioral health services in the home that we know a lot of them are doing, from case management, screening, referrals, support that way. And so that's something we're really wanting to look into as well, is this something that we can do? And if so, what does that look like to roll that out? And then our last is just continued stakeholder work. This is a continuous process. It's not going to be once this plan is out that everything is said and done and it can't change at all. And so that's really what it is we're going to keep working with stakeholders. We have to have this plan developed and started by January 1st. And also we still want to work with stakeholders of, is this working? Do the components of this plan make sense? Is what isn't working? What are the barriers and gaps that are coming up? And then along with that is continuing to identify ways of increasing the number of treatment foster care parents alongside with CDHS. And I think, and my last is next steps of what we're going to continue to do is engaging with key stakeholders, working with CDHS to create the action items affiliated with this, communicating with everyone of what this plan looks like, how it's going to be rolled out, having them understand what the Medicaid system of care is in a tandem with increasing this access, and then working with the BHA on how do we, if possible, how do we make this QBHA a process or a possibility as well. And then, so as I said earlier, this plan, after we get done with this meeting, I'm finalizing just a couple things and then we're going to send it out. So all of you should receive access to this actual plan to provide feedback. It's a short turnaround just because of our deadline, but hoping for feedback that can be sent to me by 12/20. And then by January 1st, we're going to have this plan posted to the public on the website as well for accessibility that way. And so you will all have access to that shortly. And I would love any feedback you have on it, as you are all the experts of where are those gaps, those barriers, areas that we can continue to work on. Are there any questions at the moment?
And you highlighted this, but I really do think, given the intensity of services that are needed for these kids, it is going to have to we're going to have to make sure the system of care works into any foster care setting, including treatment foster care, because that is where the intensity of the services, the rates for that intensity are reflected. You'll see words like enhanced standards assessment, enhanced MST, enhanced FFT, to really reflect that we're not talking about traditional occurrences. We're talking about a high intensity interaction, and we just need to make sure those services are available to this population. So,
Robert, on that point, could you just say more about the current state of what it looks like right now?
what the system of care plan?
Well, no, the current state. So, for any of the children and youth currently in therapeutic or treatment foster care, in terms of accessing the services that you all have included under Medicaid, what does that look like today?
Oh, we'd have to do a data poll and see, get the state ID for the kids that are in there and pull their claims. I would be completely speculating if I answered that. I don't know, Jenna, if that's something you can ask John if we have it ready or not.
Yeah, I can reach out to John and see if that's something we have data on.
Question in the chat over the definition of enhanced. Is that frequency or defined otherwise?
Yeah, so it's understanding that the kids with higher level intensity are going to require more frequent in-person encounters with the treatment team. So it is mostly around frequency and understanding that greater frequency and rigor to the evidence-based model comes at a cost to the provider. So making sure we're capturing that cost. So it might look like a monthly encounter rate instead of a 15-minute encounter rate.
Heather Walker.
Yeah, I was curious around the MST and the FFTs is not always proven to be the most effective with this population. So especially FFT, MST has some good stuff, but FFT we have not found a lot of good, and maybe it's the provider, I don't know, but we have not found a lot of good outcomes with that. So it links to my next question around, are you looking at like kind of would the partnership with some of the information that we're looking at right now, help inform the future of what kind of treatment or resource based on what the therapeutic foster parents are saying they need, or the youth are even saying they need, and working through that process together.
Yeah, we are open to specialty population models. We're doing the same thing for IDD, looking at that, kids under 8. So we're looking at different potential models. We also are going to develop our own model in Colorado so that we're not dependent on these proprietary companies. But totally open to having that conversation. It has to meet some criteria though, and people have to be in agreement because we don't want too many different models. But if you had a model for foster care you thought was a better fit, it had to be evidence-based, and it had to be for intensive and in-home. And then Jamie, I think that's the kind of thing that like our committee would love to hear, the implementation committee, about different models that folks feel like would be a good fit for specialty populations.
Yep, I'm capturing that.
Any other questions? Otherwise, Jenna, I'm not sure if it makes most sense to include your slides or maybe the draft report once you have it at the end of the day today, but happy to include that. I might be able to get it out depending on the timing this afternoon, but definitely by Monday to this group.
Yeah, I can send the slides as well.
Great. Well, if there are no other questions, thank you all for being here. And I'm going to move over to the BHA for some updates on the Children and Youth Implementation Plan.
Yay, hello, everybody. Third
Hello.
on the list. We'll see if Matt and I can keep everyone engaged on this, but I think so. We're excited about it. And so how we thought we'd use our, oh, and I'm sorry, I don't know if everybody knows, I'm Kelly Kazi, Deputy Commissioner of Children, Youth, and Families at BHA, she, hers. And then Matt, do you want to introduce yourself?
Yeah, Matt Holtman, he, him. I'm the Children and Youth Intergovernmental Liaison, and I hope folks are seeing the slide, correct?
Yes.
Thank you. Just new office space and new computer setup, so not quite sure, but if any problems, let me know.
Right. So if you go to the next slide, Matt, here's how we thought we'd use our time today with you all. And so we wanted to just do a refresh. I'm not sure how many folks might be new or know it, but we'll share a little bit of the origin story for the plan, talk about the reform that's underway, what's the future for it, and then some highlights from our listening session, but also an invitation for you all related to that and to be able to give input. Does that sound like Katie and Heather, how we'd want to use our time? And okay, very good. So a little bit on the origin story briefly. And if anyone served on our task force or the subcommittee, if you'll do a little thumbs up or use some of the emojis, but it's in statute that Commissioner Smith establishes the infrastructure and that the content of our plan came out of that work, both from the task force and then the children's subcommittee and the recommendations related to that. The plan was published publicly a year ago. So it'll be a year come January, and also my first year at BHA. And so I'm at that 1 year mark. And so the plan itself, it's on our website. It's been out. I'm hoping you all are familiar with it. I know Jamie from our BHAC committee and Katie and others have been really involved and do know this. So just for newer folks. And just a reminder that it's a 5-year plan. And it involves, and we'll share this over 12 agencies, but it's a 5-year plan. And the emphasis, which is what Matt and I are highlighting today, is that it's all about reforming the system. So it's not just about checking boxes and did you do this item or that. It's, are we reforming the system? Because that's what the public has asked us to do. Next slide. And so what we want to share with you today are there are 3 big ways in which reform is underway, reforming the system. And there was a very clear call out from community early on was that the state needed to work better together. We need to collaborate. We need to be able to connect dots to be able to make the system more seamless, easier to access, and for lots of other things. But the starting point, and this is where the plan has helped us lay the foundation, is that we're getting state departments to talk to each other, to work together and building that infrastructure to do it. So we have 12 agencies involved in the plan. It's a few more than who was in the original group, but we've added some. And we're meeting regularly, monthly. We're calling it our state steering committee. And so that group's been meeting monthly. Then Matt and I and the team meeting with each department monthly with their worker bees that are putting the action steps into place. So we're meeting with them. And then also being able to make sure that the work itself, that we're in alignment, that we're measuring our progress, and that we're making things more transparent for the public to be able to hold us accountable, not just us holding the other departments that way. And we'll talk a little bit more about that. And what we've been hearing from community also is that in addition to just connecting the dots, working more seamlessly, building that collaboration, is that they also want to make sure that we're all in alignment. So we're building one system. And so we're on a path to that and keep it in mind. And we make sure, especially you all know this, you're in the trenches, you're in communities doing this. We just want to be clear too with you all as we are with these listening sessions we're doing. We say that we've been doing both. We're doing a lot of work and there's also a lot of work to be done. So please hear that this isn't just, oh, good, we're all meeting and now we're done. It's not, but it was super important to lay the foundation to get us all working together and to be able to do the work to align. And then we'll talk more about the transparency pieces in a minute. Next. And then Matt, I think I'll kick it to you.
Yeah,
Kelly,
wait, I
actually,
need a question from Jamie.
yeah.
Oh, I'm sorry. Yeah.
That's
hey, Jamie.
okay. Hi, Kelly.
Yeah, I'm getting on a roll
Hi,
here.
Matt. Quick question is, I guess maybe this is still just the kind of the background information, but when you talk about stakeholder engagement,
Yeah.
and listening sessions, are you currently having listening sessions for specifically the Children and Youth Implementation Plan, or is that just for the rural development?
Great question, Jamie. So yes, we're doing rulemaking. And that is, and Matt can share more on that, because I think we have one more session left, but we can share more on that. And we also are currently doing listening sessions. I'll share more about that in a few minutes. We had our first one last night, and I wanted to do them earlier, but we were doing community listening sessions around the state with Commissioner Smith, and we were doing lots of rulemaking sessions. And so we thought we would get further along with those before doing them. But we had one last night. We have another one in January, and we'll share more information about that. And it's also a good flag of what we hope you'll hear from us today too, is that the plan is one piece of it and how the state's gonna reform the system, but it's not the entirety of our work. And so we'll share a little bit more about that piece too. And I'll keep an eye on the chat, but we can always come back for more questions and things.
Yeah, and if Jamie, by the end of when we get done, if you don't have answers to both when and where the next listening sessions are for rural, there's one more Monday. And then for this one, for the plan, there's one more set. There may be more in January. So with links and all of that stuff, we'll have that by the end. And as Kelly was saying, like laying the foundation and how we got here and all this collaborative work to get us on the same page. I also want to highlight that we've actually accomplished some things during that same time frame, right? Like, so it hasn't just been laying foundation and hasn't just been doing logistics. It's been a lot for sure. And these are just highlights. You guys especially in this group, I believe are well aware of these activities. If somebody wants to point something out that they're unaware of, please let me know. But we've required your help into some of these things, and I've brought it to this group in the past. But the room and board piece, that's huge. I really think that's going to keep kiddos out of child welfare. So I think that can't be overstated enough. The rule is big, like that's not nothing, right? And so rule has been drafted. It has been stakeholdered. Oh my goodness. I think we've been to 10 or 11 in person around the state. We have done 6 virtual, and there is one more in case you missed it. I think it is actually specifically targeted for counties and county folks also. But Monday, it is also on the website. I threw in chat. So if you want to register or have the link, I believe it is on that same website. Just scroll down, maybe halfway through, and you'll see that for Monday. The other piece too is I think when agencies are talking about their values and what they believe in and what they want to see done, look at their budget, right? I mean, we put our money where our values really are, and that's something that BHA has been trying to do is fund these activities that support the continuum of care for all kiddos. And so these are just 2 ways that we're doing that, but putting these funds up and blending and braiding funds to support that. Our SimHIP beds, and then our excellent work with our HCPF partners on, in this case, mobile crisis, but many aspects across the board.
And so just emphasizing in total of the tasks and things in here that there is a big emphasis on addressing the youth with complex needs. And so this were just the ways in which, some of them, in which we were going after that.
Yeah. And so as we move forward, right, there's also been a lot of conversations around system of care and all these in terminologies. And this is our attempt. And I I think it's pretty good, but this is our attempt to graphically show what we're talking about, that there is a system of care for high acuity kiddos. And we at BHA are looking at the full continuum. These are not two separate things. They are not across purposes. They are not in parallel systems, but really looking at it this way. And really, this is about how we're going to be accomplishing the system reforms that we're trying to do to get the families the services in which they need at the time that they need them. And whether that's prevention services, whether that's never high acuity kiddos, or whether that is all of the work with our high acuity kiddos. So this is that. There's also ways here, when we're looking at this, future ways to jointly create a system of care and looking at finding shared metrics for how we're going to do that. Looking within BHA, but also across all 12 state departments to see if we can begin measuring impacts to kiddos in each of these areas, right? So looking at if the joint work that we as the state are doing is improving whatever outcome or whatever metric we're trying to find. So we'll be trying to do that in this next year. That is, anybody who's done data work with our incredible data folks knows that is a lot harder said than I originally thought.
And let me just share a little bit more about that. So and we'll be sharing this more publicly once we get the metrics. We're wanting to make sure that we're measuring progress, not on, did you do 5 items of the whatever, or 62 items? Did we make an impact is what we're trying to make sure that we're demonstrating and that we're doing. And so the progress piece is that we ask steering committee members, the state folks, what are you data you collecting and what makes sense on measuring progress. And then every department has its own IT data folks. And we've gone to that interagency data group and said, what can we be using to be measuring progress in these components of the continuum, and then be able to take their recommendations and then share those and get feedback from you all, from the public. So we just wanted you to know that that's underway, taking longer than I would like to, but we want to make sure it's good, that they're good metrics and things that we can be reporting on, and then have a public facing dashboard that shows that for you.
And Jamie, before I move on, question?
Yeah, thank you. I think this is really helpful, so I really appreciate it. Because I've probably been the one that's been, tell me the difference between continuum of care and system of care. So I think this is really a good visual. Just a question, and maybe it's when you flesh this out a little bit more, or you dig into the weeds later on, but I know, because I'm helping Robert on the implementation team with the settlement agreement, that it looks like the system of care here aligns really well with the settlement agreement elements to start with. But talk about a little bit on the continuum outside of the actual system. There's no HCPF identification within that. So I don't know if this is just for high acuity youth, or where HCPF can fall into either side of that system of care, not necessarily within the settlement agreement, but within the overall continuum.
Yeah, it's a great question, Jamie, and I know there are HCPF folks probably still on the call, but can let them answer those pieces. So what we're trying to convey in this, which thank you, Jamie, for saying it's a good start on it, that whether or not we're talking about kids with high complex needs, there is a continuum, a behavioral health continuum that they would go through and get services and all of that. The emphasis, though, in this, why we're showing you also that system of care, even though it's used more often with kids with high complex needs, it's still part of that continuum. And so what we're showing within this is that there are these components. BHA is responsible for the uninsured kids that need the system of care too, or the underinsured. So this is where we're co-creating with HCPF. And the premise, the starting point has been Medicaid and what they're needing for the system of care. And BHA is working really hard with them on making sure that for any kid, the ones that we're covering, I shouldn't say any kid, but for the uninsured, underinsured, that those services will be available too. And then it's also just part of a larger continuum. And so HCPF can speak to the other pieces, but what I wanted to, what we also want to show in here is that for other audiences, you all know the system of care in that language and reference, but for the other audiences that we're in, they just want to make sure that any kid, my kid doesn't have to be high complex needs to be able to get something. And so that's what we were trying to depict with this. One other note is that in our year one of the plan, with the emphasis being on system of care, ACC, all that, we are showing the state departments within here, and I know it's acronyms. Sorry about that, friends, if you don't know all the acronyms of it, but we're showing the state departments where they've been weighing in more heavily in this year one. But just wanted to say all of the agencies are playing a role, but this is just depicting the year one piece of it. Jamie, does that help answer your question?
Yes, but I saw Robert come off camera, so maybe, do you have any thoughts on the HCPF part of that?
Yeah, I think Kelly covered it in that last statement. That obviously in the prevention space, and some of the, I would say we're trying to increase our footprint in the transitional services space through waivers, but it's not as prevalent. Obviously, there's a whole treatment continuum outside of just system of care for the high acuity kids that we cover. But we're trying to get more into the housing and more into that transitional space through waivers. But honestly, with the new administration, we got to kind of figure that out.
Work in progress. Thank you.
Kelly, did you want to say anything else here before we move?
Just one other piece is that there, I shared a little bit, and Matt and I did, on the measuring progress. So when we have that, we'll be able to show you that too and get your input, and we will for public input also. The other piece is that there's also a lot more knowledge, information we need to be able to reform the system. And so that's showing up in a couple of things. One is that we put in a budget request, which I think most of you know, and Heather and Katie, I don't know if you put it out to the group, but we have a request to do some studies relating to capacity assessment, relating to a fiscal analysis. How do we use the money we have and leverage that to get to the things that we need? And we're going to probably emphasize that a lot around the system of care components and some of that, but we put in a budget request for that. The other is that we have TAC working with us to give recommendations on how we can bolster, work with other departments on that prevention transition side, and also to give us a recommendation on a best practice around a governance structure, not just for this youth plan, but for our youth work in general. And so that's coming. And then I mentioned again, the publicly facing dashboard so that we can be transparent about progress that we're making. Okay, couple more slides. And Heather and Katie, are we okay on time? And team, am I going to deep in the weeds on things that? Okay.
I think
All right.
we're good. We have 30 minutes left, and after this, Kelly, we have Susie and Paul to talk about the substance use, so we're good.
Good. Okay. So thanks. So we wanted to share a bit then on just the future of the plan, and again, the future of just our work, combining it so that it's not just the plan, it's in total what BHA is doing with our programs, with the things that we're needing to do to reform. So Jamie, you'd asked earlier, so we had a listening session last night, and I can't remember the exact number, Matt. I think it was 257 people registered, which was awesome. And in the registration for the event, we asked them if they have any questions for BHA. So we had, I don't know, over 100 questions people had put in, which was great. Big and small, they were great. We have another one on January 16th. Matt will put a link in the chat if you haven't already. I would love it if you all, welcome to attend. And if you did last night and I didn't see your name or recognize it, sorry about that. If you could share with not just with your networks, like professional piece, but in your communities, if there are folks you all work with, we'd love to make sure that we're getting kind of everyday people, those with lived experience, caregivers. That would be great. We're also going to publish a progress report on the plan and the work probably in February. We put it out in January. We're going to come back and do the progress report. And so that will come out. And then we have a landing page. Matt, thanks for putting that in. A landing page to make it easier for the public between CDHS, HCCUF, BHA to just go to the one spot and get more resources. We still have Performance Hub and all of that, but we wanted a landing page to make it easier for folks. You are probably aware of all the JBC, SMART Act hearings coming up. And then with the driving of the work, the state steering committee is having, we needed to get that group organized and infrastructure in place, get us working together and collaborating, connect those dots, all of that. But that's not going to be the entirety of it. We're now shifting to be able to keep that group will continue to work and fulfill the action items and do all of that. And we'll adjust the plan as things come up. But we want to have more community member engagement in the work. And so we're going to get to recommendations from TAC on a governance structure and those things. But in the meantime, I want thought partners with me in the work as I'm leading this with BHA. And so I'm going to be reaching out to community members and others this month, next month, and starting that group, I hope in January, to be able to meet with me and also help inform the work and help with prioritization and things like that. And then I wanted to share with you all, and then I'll pause for questions and things. I wanted to just share with you what we've been, what we shared last night for the listening session, and then what's coming up in January. And there'll be opportunities for you all to weigh in if you participate in that. And then we can also take your input at any time. But this is what we've been sharing. We shared this progress report with community, and then we spent the bulk of the time in breakouts hearing from folks, and we have a ton of feedback, input from them. So we shared with them these 3 questions and then asked them to just respond. We've been out in community a lot, both through the community listening sessions, which I participated in with Commissioner, and also with rulemaking. And then just with advocates meeting with us regularly. The biggest themes we've been hearing are around youth for priorities, youth with SUD, youth with IDD, lack of workforce, and then lack of services in particular communities. So we bounced this off of community and said, here's what we've been hearing. Are we on the right track with this? What would you prioritize? And then things around elevating local things that are working that we might be able to scale or look at, and the third around celebrating successes. So just to say there were over 150 some folks that were in the session last night. So we've taken all of that feedback, and then we're going to process all of that and then put those themes responses on our landing page. We're also going to do written responses to all of the questions that folks have asked us. Some are duplicative in that, but we're going to answer all their questions and then also put that on the landing page. And that'll come after the next session in January, so that the themes and all that, we can just combine all that. And if there still is high demand, we can add more listening sessions. So that's probably going to be the case and can do that too. And then, Matt, did I cover we also sent them these questions back out to them. So for those that didn't have enough time or weren't used to speaking up in public meetings or in the breakouts and that, we could still capture their input. So with that, I'm gonna pause and just see if there's questions or comments, and Jamie, go for it.
Thank you. I'm looking at the spreadsheet with the children and youth tasks, which I think there's definitely been progress, which is great in identifying, which tasks are going in what year and all of that. I was under the impression, and maybe I'm incorrect, that there were some that were completed for year 1 already, but I'm not seeing any in the status category that show completed. Most of them are in progress, pending, or not started yet for year 1.
Yeah, Jamie, I love how you dig deep. I love it. And so we'll look at the spreadsheet, and so we have lots of info on this, and Matt and I are still figuring out how best to convey the information. So here's a summary for Jamie and others, and you will get the slides and do all that. So we, instead of the taskbars and spreadsheet stuff, what's an easy way to just get the status? And again, BHA, CDHS, HCCUF were the primary action items in these 19 in this first year, and because a lot also around youth with complex needs. So that's why we're seeing them. And then we have other stats in progress for all of the departments. And like year 2 is already underway. And so there's a lot of work happening beyond just this. But Jamie, is this an easier way for you to better see what was done? And
Yeah, I mean, this is great. Thank you. It would be helpful maybe to tie back the action items to maybe the numbers on the spreadsheet so that we can kind of do that crosswalk back, but also when we're asked kind of in real time from like the commissioners or other people, like where are we at with the implementation plan? That's where I'm going to go, and maybe that's not where I should go. So where should I go to get like the most update information?
yeah, great question, because ideally it'll be the dashboard when we have that ready and feeding that in it. And then Jamie, you can let us know, this is how best you convey the info, because some folks are gonna want, hey, where's my checklist of the 19 things? And then other times, Matt and I are hearing, we don't care about the 19 things, tell me what impact it's made by doing the 19 things. So you let me know what would be helpful, but for now, I think that sheet is probably that most current. And also, if you know you're gonna be meeting with somebody and you want us to give you a quick summation, Matt and I are happy to do that too. So you can just let us know, but that probably is the most current. And these 2 that are in blue on in progress this month should be done. So that's why I'm waiting till January to really update the progress report, and then we'll probably put it out in February.
That's awesome. Thank you. One more
Yeah.
question. I'm so
Sure.
sorry.
That's okay.
The details around it, right? So like, oh, can you put that back
Oh,
up?
do you want it back?
There was
Sorry,
one, yeah,
Oh,
there was one on there that
yeah. Let me, sorry. There you go. I hope, there you go.
yeah, so like, one of the in progress ones in the middle of the page that talks about you're gonna identify and analyze to what extent core service dollars are utilized for Medicaid eligible children and families. And you said that one and the other one in progress are gonna be marked as completed. Where can we find the details to what you identified and analyzed to what extent core services are utilized?
Yeah, so, and we are working for that one particular. Amy Shangula obviously is the core service administrator for CDHS. Work very closely with her and April over there at DCW to do this. They did this in partnership with HCCUF, so they have some very good numbers on what this looks like. We ask again just for higher level. I don't need the exact numbers. I don't need those quite that detail. Amy has all of that. The biggest piece that we're checking on is to make sure this has been done, and then it will be right to see how we can help and improve whatever that is, right? But yes, we had a meeting with them. I think it was last week, actually, Jamie, to make sure that we were on track to meet this one. And they have some pretty solid numbers and some data around how much core dollars are being utilized, what they believe for Medicaid eligible services. Not that service is available, but that's in that region or those types of things. There's still reasons why core dollars are being utilized for that, but that it is on a Medicaid eligible service.
And Jamie, we can ask, I don't see a CDHS person on the call, but we can ask and then let Heather know when that information or how it'll be available or how to better know what the numbers mean, if that's what you're interested in.
Yeah, I mean, this one sticks out to me because there was a request for a reduction in core with the governor's budget. So we're really digging into core at the county level and have been for quite a while. So I'd love to get the details behind that. But I think just in general, right? Like, can we click on something and see what the details are behind those action items and what was actually completed as far as those go?
Jamie, I love that. At the moment, the answer's no, but But Matt and I will make note of that, because just as we're wrapping up year one and figuring out how do people want to use the plan and the information and all of that, we'll add this in, because we do know they're completed. It's not just like we go, okay, CDHS, check the box. And it's like, we really do dig deep and need to make sure we're that accountability piece too for the other departments. So Jamie, we'll make a note of that and see if there's something like that we can put for our dashboard, something like that, that's the publicly facing piece, so people in real time can just see what it meant when we just say the one task. One of our tasks is launch Bossos. So there's a lot to click on that to do, but somebody might not know what that is and want to click on it and see. So I love that idea.
Yeah, and
Okay.
also just
Thank
FYI,
you.
Jamie, we've talked about that a little bit, and there's also a significant cost with some of the technology pieces to put some of that up right now. It's not a no. It's we find a lot of value in it, and yet how much what's the cost on it too? Like I just know that was definitely a piece when I brought it up earlier this year. So
Yeah, I get that. And maybe it's just, refer to BHA website on Bossos for more
sure. Yeah.
on
Yeah.
Yep.
upcoming launch or something like that. But yeah, I think if some of these could have a little more, especially on the analysis ones, would be really great.
Yeah.
Thanks
Love
for
that.
considering.
Yeah, I love that.
Thank you, Jamie. If that's it for folks, I'm chewing into Susie's and Paul's time, and I know they want to share their stuff. So I will
Yes.
stop. Thank you.
Thank you both so much. Lots more to come, but the extra detail is super helpful. Paul and Susie, thank you for being here today. Just to give you some additional context too, this group in Tackling Barriers has been trying to keep track of what's happening with substance use disorder treatment for youth in the continuum. Have we made any progress? I will just quickly take us back all the way to July of 2022 when Youth Recovery Center at Valley View Hospital announced that they were closing. They were the only inpatient SUD hospital for adolescents that took Medicaid. And at that time, 2.5 years ago, we did all of this analysis, all of these conversations with providers. We looked at all of the CANS data around the significant treatment need that youth have in residential settings that really need substance use disorder treatment. And then, with the ARPA funding through House Bill 221283, that's really what gave the BHA some funding to contract with Signal, and Signal contracted out to stand up and work with Denver Health for some withdrawal management beds for youth. And then Jefferson Center took a lot longer to actually open on a limited basis, some of those beds. And then we heard recently there was some issues going on there. They were closed because of a child death recently. And they're continuing to struggle significantly with workforce retention and recruitment. So this has we know it's a huge need in our continuum of care, and especially when we talk about children and youth with high acuity needs. And we just want to hear any updates from you all that the BHA has been working on, and also how you are coordinating with HCPF and with CDHS on any of the expansion of care at this level.
Great, thank you.
So
Heather, that's
yeah,
an
go ahead.
excellent introduction, and maybe Susan and I can introduce ourselves, and then I'll let her give a more detailed introduction. But that's a great history. So sorry, Susie, I'll just introduce myself and then hand it to you. So I'm Paul Barnett, pronouns he, him. I'm the Director of Child, Youth, and Family Services at the Behavioral Health Administration.
Hi, and I am Susie Morris, and I am also on the Child, Youth, and Family team working under Paul, and I am the program manager for our youth residential program that you have mentioned. So I'll pass back to you, Paul. Do you want to first?
Yeah, so I think our primary initiative that we're currently working on, and we're of course very aware of the intense need in this area, is just what you mentioned, Heather, which is the program that Susie's overseeing. So Susie, definitely just give us any, additional updated details that you have, and we'll go from there. Hopefully we have a few minutes to, have a little conversation as well.
Yeah, let me update you. It's like perfect timing because I just actually met with Signal this morning, and so have some great information to share with you and update. You gave some great higher level information, which I was going to share, but I just wanted to clarify a couple things that I don't want to assume that folks do know. And so, as you had mentioned, Signal has subcontracted with Jefferson Center, that we often are hearing and referred to as YRR, and then Denver Health. And both of those programs are meeting two separate needs. And so I just wanted to quick mention that for clarity. And so Denver Health is being subcontracted at an ASAM 3.7 level of care, which is our medically monitored high intensity inpatient service withdrawal management beds. And so they opened in, May of 2023. And they have 3 beds that they are currently utilizing for withdrawal management in their psychiatric unit. They have currently served, as of September 30th, they have served 53 youth. And then we have YRR, Jefferson Center, which does have 16 beds. Beds aren't the issue, as you have already stated. Workforce is a challenge, recruitment and retention. And so it took a little bit to get them up and running. They are licensed at an ASAM 3.5, which is our clinically managed high intensity residential service said beds. And so with them opening up in May of 24, they opened up with 5 beds, again, because they didn't have enough staff to open up all 16 of those beds. As you likely know, they were open for a month, and then they wound up having to close, I think, in June and reopened in July, again, because of staffing challenges. And then you likely have heard most recently that they closed in September due to the youth that had died in the program. And so we have an ongoing investigation currently. To date, they have served 8 youth in that program. And so what I have learned as of this morning is that Jefferson Center does have intentions of reopening up those 5 beds in mid-December. I don't have an exact date. I was just told mid-December. They still have part of the challenge with them reopening. Again, while this was not a forced closure or shutdown, they had to shut the facility down, or those beds down, because they did not have enough staffing. So they have an ongoing investigation, and 4 of those staff are on administrative leave. And so they had to get busy trying to rehire staff. Currently, because the investigation is still going on, those staff are still on administrative leave, so it's just taken a little bit of time. So I think that they have enough staff hired, and then they're also utilizing other creative solutions, pulling from other programs and other staff while they continue to hire. They do again intend to open up back up to 5 beds. And they are working with Value Op, which is a consulting firm, to really help them navigate the recruiting and the onboarding and the retention challenges that they're having. But I think that part of what I would, I think that we maybe all appreciate is that in part why it's so hard, the staffing is so hard for these ASAM 3.5, 3.7 beds is that it requires medical staffing. It's the licensing requirements that require the medical staffing SUD licensed, licensed staff. And one thing that I think that they are finding is that they're just not able, especially for those overnight shifts, able to find individuals who have the education, the training, and the experience to work with these challenging youth. And so they'll hire, and sometimes they have people who don't even show up for the job, or they have people who show up and then are only able to stay within the program for maybe a week. So that's just really been a challenge. I would mention that, Signal is working with Jefferson Center on an action plan that's due at the end of this month that will give us, the VHA and Signal, a better opportunity to work with them in addressing how are we going to get the remaining beds open. So I don't have that information to share, but perhaps I can come by and give you an update in the future. Signal is working. I know there's been lots of questions about what else are we doing? What other options are there? Has Signal looked at other providers? And the sad answer to that is that there really aren't any other providers. And again, in part, that is due to licensing. It also is due to just having the building. As you know, that these are ARPA funds, and so we do have a time frame in which we're able to spend them. And so I think some of the challenges too is finding the facilities, someone with the facility and having the beds already available and could have a quick turnaround time. But licensing truly has been a challenge. And as Signal has had these conversations with other providers, they basically are just saying, no, we do not want to do this work due to the difficulty in the staffing and the licensing. And I think the other component of this that we're getting feedback from providers, it's not just the licensing and the staffing, but it also is that, looking at this from a larger perspective and from the systems level is that we also don't have services to effectively help with step down after they leave Jefferson Center. And so we don't have adequate step down services, in-home services to support families with some of their challenging family system dynamics that are feeding into some of these challenges with youth. And we don't really have sufficient wraparound services. And again, looking at the complexity of a lot of these kids are involved in child welfare. They have, the legal system, challenges with schooling. So I think they're a little resistant and intimidated by the lack of support and the lack of services even beyond providing residential care. However, I think some of the things that Signal is working on is that they are working on, they have identified, we've had some conversations about, well, what about QRTPs? What about PRTFs? Could they be licensed? And so we are looking into this. We are having conversations. We do have some that are interested. However, again, it's about that specialized care. So PRTFs would be great in that, they offer more of that medical environment, but it's also very specialized care. And so we, one of the conversations that, Signal is having is around, if you are interested, then you would have to, because you would have to develop a more specialized care and service for youth with substance use disorder needs. And so that has also been a bit of a barrier because they would have to change or create other systems of care. And but we are having those conversations. And so I hope that we'll have more maybe to share around that, maybe in this next year, new year. They had mentioned, for example, let me scroll here. I took so many notes. a lot of updates here. So one of the QRTPs that Signal had identified was Southern Peaks, and they are a viable option. Again, one of the challenges that were identified is, again, their treatment model, and that they would have to be able to provide that subspecialty of said services, and of course, looking into those licensing requirements. So, and then the other option, the thing that Signal is looking at, again, to help support families within that transition and that step down after residential care, is the PHP options, which are the partial hospitalization programs. So they're really like kind of focusing on developing more intensive outpatient treatment opportunities for families, such as in-home supports, mentoring, and peer support services. So they're working on those. And we only have a few minutes, but I want to pause for a moment to see if there are any questions. Oh, we
Yeah,
are.
I'm so sorry. We're at
Okay.
3.
There's a lot to share, but we'll come back.
Yeah, it actually would be really great if you guys could come back. I know there's a lot of questions, just given all those challenges, Susie, that you outlined, it still just feels like, but what is our plan? Like, how do we elevate this as a priority across all 3 of the state departments and really address it? Because 3 beds at Denver Health, 5 at Jefferson Center, and also at risk of closure, of losing those limited ones that we've created, is really, really concerning and is a top priority. So yeah, just want to dedicate more time to this and have you guys coming back. But thank you for being here today. And everyone else, thank you so much for being here. The next meeting is January 3rd, and Katie did put in the survey at the beginning of the meeting. Please fill it out if you haven't already. She also sent it over email, but otherwise we'll reconvene January 3rd, which is a Friday, 1:30 to 3. And Paul and Susie, we will reach out to you to try and coordinate with your schedules. Thanks, everyone. Have a great weekend. Bye.